James, and thanks to the organisers for asking me to speak. And thank you all for coming here on a Saturday morning. Just want to echo Peter's comments. It's really impressive that you're all here wanting to learn on a Saturday morning. So you've sort of had a morning of lots of great information, great talks, lots of great adult medicine. Your heads are probably full of a lot of facts and figures, and you're struggling to think of how you're going to remember all these things. And this is probably not dissimilar to how you feel when you come into a paediatric term, that you've spent a lot of your medical degree, a lot of your internship, a lot of your residency, getting your head filled with lots of adult facts. And so it can be quite challenging then coming in to manage a sick child. What I want you to do just at the start is maybe you can close your eyes and just have a think of a situation that would terrify you about looking after a sick child as a resident. Just take a moment to think of a situation or a scenario that you might have heard of, that you might have been involved in, that you'd be scared about approaching. And I want you to just keep that thought in your mind, keep that scenario. Think of what scares you about that. Okay, so we'll come back to that in a sec. And I think there's a lot that scares us about looking after sick children. I want to share with you that I'm also very anxious when I go to work about the sick child that might come in. I'm doing an evening shift this evening, and at about 2 o'clock, my resting heart rate, my 42 resting heart rate, Peter, will start rising up a little bit as I think of what are all the things that are going to come in on this shift that are going to treat me. So the first thing that it's my job to tell you as a paediatric emergency physician, as a paediatrician, paediatric emergency physician, is that children are not little adults. So you've probably heard this before. We start every APLS course with this message: children are not little adults. Every paediatrician will tell you this, every acute care course in paediatrics. And there's some pretty good reasons we say this. There are physical differences with children. They're smaller, their heads are bigger, their airway's different. There's some physiological differences. The way that they respond to shock is different. They don't drop their blood pressure like adults do. They preserve that, they compensate well. Their heart rate can be quite high compared to what you're used to seeing in adults. The numbers are all different. There's some pretty important psychological differences. We often can't communicate with them. We can't explain to them what's going on. They're often scared. They've got parents who are also scared that we have to deal with. And they have different diseases. So we can sort of come to looking after sick children feeling like, well, I've got absolutely no idea. I've got no skills. There's no way that I'm the right person to be looking after a sick child. I've done, I did a 6-year medical degree. Of that 6 years of medicine, I spent 10 weeks learning about paediatrics, and even less of that 10 weeks learning about sick children. I spent a lot of it learning about obscure genetic disorders and dysmorphology. So how am I prepared to look after a sick child when I'm telling you that, children are not little adults? There's all these differences. There's only a secret society of paediatric emergency physicians who can do this. The good news is that children don't grow up to be elephants. So I sometimes worry that by telling you all that children are not little adults and highlighting all the differences, we do it for a good reason, but we get to the point where we convince you that you've got nothing to offer, that there's no way that you could possibly contribute to looking after a sick child. But what I hope you take away from this talk is that you've actually got lots of skills. You've done lots of stuff in your medical degree that's applicable. You've got lots of knowledge that's applicable. And to not throw away everything you already know about humans and about medicine, about physiology, about basic diseases, but think about how you can build on what you know and specifically apply that to paediatrics. And as an example of that, so when I did my FRACP exam, it's very similar to the adult exam in its structure. You do a basic sciences exam, you do a clinical sciences exam. So a lot of us prepared by doing the adult basic science past papers because it's the same science, it's the same core knowledge. What is different is some of the diseases and the disease processes and the specific diseases that happen. So you also have lots of non-technical skills that are going to help you look after children. You have great problem-solving skills. Probably many of you through uni did lots of problem-based learning, so you're very good at problem solving, you're very resourceful. You know, we all know in this day and age of information, you all know where to find information. You know where to get help. You know what resources are available to you. You know what environment you're in. So don't forget all of that. Use all of that information and recognise the strengths you've got in those and how you're going to apply them to a child. And you've got basic clinical skills, so you know how to examine an adult. You know the meaning of different signs and symptoms. Again, when we did our paediatrics exam, I used my Talley and O'Connor, which was the book that I used through medical school to examine adults, and a lot of the signs and symptoms are the same. We just have to apply them a bit differently. So I want you to go back to your scenario, and if you didn't have a scenario, I'll give you another scenario. The actual scenario doesn't really matter, but you can think of the situation that you were thinking about and why it stresses you and what that was about. But this would not be an uncommon one. You might be called to a child on the paediatric ward. You might be on the evening shift, you might be a medical registrar, you might be a resident who's part of the responding team, you might be a first-year SRMO at a children's hospital on secondment to a non-tertiary unit, or you might be in an emergency department and a 10-month-old girl is brought in. She's got breathing difficulty. If you're on the ward, she's been diagnosed with bronchiolitis, but it's 3 o'clock in the morning, she's febrile and she's tachycardic and she's in the red zone for everything, and you're being called on as part of a team or by yourself to try and work out what's going on and what's happening here. You've got a very anxious, concerned parent, and you can arrive at this feeling like, I've got no idea, what am I possibly going to be able to do to help here? So what I want to try and do is give you a little system and approach that works for me, but I want you to think about my approach, and you might modify it, that there might be different things that work for you. So the way I sort of think of, and I still think of this, I'll be thinking like this evening when I do my evening shift in emergency. I think about this on every time I look at a sick child is what's my approach? So the first thing is resuscitation. So does this child need immediate resuscitation? And do they need some immediate interventions? And we'll talk through some of those. And then because I'm an emergency physician, I think in my primary and secondary survey, so once I've done my thinking about does this child need resuscitation and any immediate interventions, I'm going to think about my secondary survey. So we'll go through some of the things that I cover in a secondary survey, and that's essentially history and examination, and then that's followed by clinical reasoning, so trying to work out what's going on. How do I work out what's going on with this child? And then I'll think about whether there's some definitive management that needs to go in, and all the while I'll be thinking about how I'm communicating this to the parents, to the other people that I'm working with, and whoever else I need to communicate with. So resuscitation in paediatrics, if we think about basic life support, it's essentially the same as you've learnt for adult life support. So we still follow a doctor's ABC approach, but there are some subtle differences. But if you don't know the subtle differences and you just know how to do basic life support on an adult, I would say you can do the same thing for a child. It's better than standing back and doing nothing. But I'll go through some of the differences. And they're relatively minor. So the DRS is the same. You're going to check for dangers, you're going to assess for response, and you're going to send for help, and you're going to know what system to call for help is wherever you're working. So the airway was something I mentioned before as a physical difference in children. So children have big heads, their airway is a bit more anterior. So the positioning that we need to do to get a child's airway straight is going to be a little bit different to how we do it in adults. And it's going to be age dependent. So essentially in a younger child, we want them in the neutral position, which seems different to what we do with adults, but when you consider that the head of a child is bigger, they're putting their airway in that straight line when you have them in the neutral position. It's just that with an adult, you have to put something in there to get that line, because their head's not proportionally as big. Our heads aren't proportionally as big as our bodies. As we get older, we start talking about the sniffing position, and children over 8, 10 or in their teenage years, you often could do the same positioning that you do for an adult. Pretty much like an adult, we're only going to suction under direct vision. Children have very strong vagal responses, so if we do lots of blind suctioning, we can actually make things worse, and we can prompt a vagal response that stops them breathing. So we're only going to suction if we think there's something to suction and if we can see something. We have the same airway adjuncts in children. We have oropharyngeal airways. There's a subtle difference. It's actually easier to put in an oropharyngeal airway in a child because you just put a tongue depressor in and put it in the right way around. We don't bother about twisting around. In terms of supporting a child's airway, I find jaw thrust to be the single most useful thing that you can do in opening a child's airway, and it's much easier than the bearded 45-year-old man who you're struggling to get in there and lift their jaw up. It's very easy. You can get your fingers in behind their jaw and with a relatively minimal amount of pressure give them some jaw thrust. So it's actually an easier thing to do managing, I think, a child's airway from a basic life support point of view than an adult. In breathing, breathing's essentially going to be the same. We've got to have the same tools. We've got our bag valve mask. If you know how to use a bag valve mask, you can use it in a child. In fact, it's easier. We don't have, like I said, we don't have beards to contend with. We have different sized equipment, which you'll get familiar with. But you can always use a bigger bag to bag a smaller child. So if all you've got is an adult bag and that's what you're used to, you can use that to bag a child. You just watch what you're doing with chest rise and don't press as hard. We want a good seal around our mask, and we've got different mask sizes, but you'll actually find that achieving a seal on a paediatric mask is a lot easier than doing it on an adult, because you can often do it with one hand if they're small enough, and you can use your same sort of C grip, but you can also use two hands if you've got two people. So it's actually something that's relatively easier. The important thing about breathing in children that's a bit different to adults is breathing problems are the most common things in children. And breathing difficulties and breathing abnormalities are the most common pathway to cardiac arrest in a child, rather than primary cardiac problems. And that's reflected in some of the paediatric algorithms that still, say to do 2 breaths in your basic life support algorithm. But if you don't remember to do that, if you just go straight in and start your compressions and then do your breaths, that's going to be fine as well. Because if a child is truly arrested, it probably doesn't matter whether you give them the 2 breaths or not. From a circulation point of view, as I said, James presented some great cases of adults where you're struggling to work out, is this a cardiac problem, is this a breathing problem? The easy thing in children is it's going to be a breathing problem. So if a child is in cardiac arrest, it's often because of a breathing problem. If they've got a heart problem, they're a lot rarer, and we're talking about specialised paediatrics then, children with congenital heart disease. Sometimes arrhythmias, which are not that uncommon, but that are much more simple than the arrhythmias Peter showed you this morning on ECGs of adults. It's often SVT really is the most common arrhythmia in children. And if you know how to manage adult SVT, you know how to manage paediatric SVT. So compressions are the same, it's just that our technique is different because we've got a physically smaller child, so they're actually easier. We can use one hand, we can use an encircling technique if it's a much smaller baby, or if they're an older child, we use our 2 hands. Now the ratio is 15:2 that we do in children, but if that falls out of your head and you're used to doing your 30:2, do 30:2. In an arrest situation, it probably doesn't make a big difference. So thinking of our initial resuscitation, I think if you've done adult life support, you've got all the tools to be able to resuscitate a child. If you anticipate that it's going to be a situation that you're going to be in, it's worth practicing, investing a bit of time, as Peter talked about, outside your work, just going to a mannequin and making sure that you're comfortable with some of the equipment and the techniques needed for paediatric basic life support. So we've done our resuscitation. The interventions are relatively simple in children. It's going to be oxygen. It might be some IV access, and IV access can be challenging in children, but in an arrested situation, if you can't get access, you can put an intraosseous in, and there's many points you can put an intraosseous in, and it's no mark of failure. I've put many intraosseous lines in children in arrest situations. It's not a mark of failure if you can't get a line in a child. So they're the things. It's going to be oxygen, it might be intravascular access, and your resuscitation medications, which are going to be similar to your adult medications. So now we're going to assume that we've got a child who's not arrested, that we don't need to rush in and do things for immediately. We might put some oxygen on, which is always a good start if the child is breathing hard and a bit hypoxic. And we're going to go to our secondary survey. So it's that situation where we've actually got a bit of time to sit down and take a bit more in. We're going to get a bit of a history from the parents. I think the single most useful question to ask a parent in that situation is, what are you worried about now? Or if they've come into emergency with a long history, what is it that's actually brought you in now rather than this morning or yesterday? Or what are your current worries now that you weren't worried about a couple of hours ago? I think that's a really useful question to ask. And then we're going to go through a brief history trying to work out how we got to where we are. And you've got those skills. You can all take history. Examining a child can be quite challenging because they don't do what we tell them to do. They're often crying. That makes it hard to listen to their lungs. They're often, we're a bit nervous about handling them. So the good thing is that most of your examination in a sick child can be done just by looking at the child without actually touching them. And so I talk about the 3 O's when I examine a child. So observation. So just look at them. You can count their respiratory rate when you're looking at them. If they're on a monitor, you actually will get lots of information about their heart rate and saturations. You can get an idea of whether they're alert, are they interactive, are they looking around, are they comfortable with their parent, do they seem quiet, are they asleep, are they not responding, are they floppy? You can get all of that information just by looking at them. At some point though, you might need to have a listen to their lungs, listen to their heart, and you do that opportunistically. So that's the second O, is do it opportunistically. It doesn't have to be in the rigid order that you would do when you're examining an adult. So I often get in if they're quiet and listen to the heart first, because for me, the single most useful thing to do when you're examining a sick child is to count the heart rate. And I often say that at work. I say, if you do nothing else when you're examining this child, just count the heart rate and tell me the heart rate. And it's often good to do that first before they get upset or they start crying. And that leads into the next bit, which is be as objective as you can. So we often in paediatrics talk about this magical skill that we all have of picking the sick child. You know, I can walk in and say, oh, that child's sick and that child's well, and I've just got this special power of being able to do that. So the secret is we don't have that special power of being able to do that. We try and be as objective as we can. So we try and actually say, okay, I might think this child is unwell, but what makes me say that? So what makes me say a child is unwell is being objective about it. And so we can use an ABCD approach to that as well. We can talk about their alertness. We can look at their breathing and say, are they breathing fast? Do they seem to be struggling to breathe? We can look at their circulation, and again, I come back to heart rate, that they're tachycardic, that their perfusion's poor. And so those things, that ABCD approach and D, so what's their neurological status like? And you can then start to get a bit more information from your history about fluids in and fluids out, and put all of that objective information together to make you decide whether you think a child is well or unwell. If you do nothing else, my single message is count the heart rate. So then you're going to go into your clinical reasoning and your management. And I think it's useful to ask yourself when you're reasoning about this, you know, is the diagnosis right? Do I need to think about other things? And there are some common things that can masquerade as other things. So one of the common things is abdominal pain in children can actually be pneumonia. So listen to the lungs when you've got a child with abdominal pain. The other thing in the middle of sort of bronchiolitis season, when you're seeing lots of children with breathing difficulties, is think, could this one be the child that's actually cardiac? So listen to the heart, see if you can feel the femoral pulses, have a think about whether this is actually that rare child that might be cardiac. I'm not going to go a whole lot into investigations, because one of the beauties of paediatrics is we don't tend to do a whole lot of investigations, and they don't often in a sick child necessarily help us that much work out what's going on. It's often very clinical, and those initial basic interventions, and then you can often ask for help, ask the paediatrician on call, ask the emergency staff specialist who's around about advice on investigations. So the 2 things that I want you to take home again was heart rate. So persistent tachycardia is a red flag for me with a sick child, and it means you need to think that you might need to intervene either with fluids, antibiotics, that this could be sepsis, that there's something else going on. And persistent parental concern. So all parents will be concerned, but if a parent is persistently concerned despite you being able to reassure them, and this is a message for me as well when I'm on, if I see a child and I think they're okay and I explain that to the parents and they're persistently concerned, it makes me think to myself, what am I missing? Let me go back and think about this again and write a list of what I might be missing. And this is a bit like teaching you guys to suck eggs, right? Talking to you about communication, but I think it's important to have a way that you're communicating and a structure to your communication. And you will all have your own different systems, but it's worth just thinking about that and reflecting on how you're going to communicate with the parents what's going on and how you're going to communicate to other people in the team. And when you call for help, how are you going to communicate what you're worried about when you call for help? And I often find my one little tip when you're calling in any situation, but especially about a sick child, is to start at the end of the story. Don't start at the beginning of the story. So by that I mean often we want to tell a history from the beginning, from the 4 days ago when this child started with their runny nose, but I would start with the end. So I'm here with this child and I'm worried that they're acutely deteriorating because their breathing is worse and they're persistently tachycardic, and this is what I'm worried about. And then I'll tell you how we got there. The other thing that you're really lucky about in terms of looking after children is there's a whole lot of good resources around. So most of you will be familiar with the Royal Children's Hospital Melbourne and their paediatric guidelines, which are excellent, really simple, easy to read. But New South Wales actually has some really good resources that are a little bit harder to find, but they're actually just as valuable. And not all of them are completely in date, but paediatric emergency is not such a high-powered field that it's advancing at a rapid rate of knots that things become out of date that quickly. So there's a whole lot of guidelines on this website, the Kids and Families website, that look at the common acute presentations for paediatrics. So we've got croup, we've got head injury, we've got bronchiolitis, asthma, but there's a really good recognition of serious illness matrix that it's worth having a read of. And I think the useful things for this are the things, as well as in your ABC assessment, the also consider box is quite good. So they talk about considering parental concern, whether the child has other illnesses, but down the bottom is, have they recently been in hospital already? Or have they had multiple presentations with the same thing, which is that thing about maybe I need to think that something else is going on. So hopefully what I've sort of conveyed is that, yes, paediatrics can be a specialised field, that there can be different diseases and illnesses, but actually I don't want you to throw out everything you already know. I want you to think about how you can apply what you already know and be sensible about that in applying that to the care of sick children. And if there's time, I'm happy to take questions, or I'll be around in the break as well.
There is no time now.